I would like to welcome Dr. Daniel Nead today. Dr. Nead, he is the Integrated Health Director at Malama Ikeola Health Center over on Maui, a licensed psychologist here in the state. And he will be talking to us today about integrated primary care. So I will hand it over to him. Thank you, Dr. Nead.
No problem. Thank you, Summer, and thank you to everyone for taking some time from your lunch break to listen to me ramble on a bit. Like Summer said, I wanted to spend some time today talking about integrated primary care and some integrated care models. I think we've all seen the demand for behavioral health services has increased significantly since the pandemic started, and along with some other changes in the healthcare system, there's been a lot of talk about ways that we can provide behavioral health and mental health care to populations who may not otherwise have it or do it in different ways. And this is one of those ways that we can sort of look at other ways to provide services to patients and to the community in ways that we may not have had training or a lot of formal education in. So, like Summer said, I am the Integrated Health Director at Malama Ikeola over on Maui. We are a federally qualified healthcare center. So we cover primary care for children, adults, and pretty much from birth to death. We also have an OBGYN department, a dental department, and then a lot of support services like community health workers. My department includes behavioral health, behavioral medicine, substance use, and nutrition and psychiatry. So we kind of work in an integrated fashion and in a lot of formal and informal ways. But part of the reason that we have this department set up the way that we do is because of the needs of our community and the ways that we needed to find some other ways to reach out to them with these services. I also have no disclosures to make, just in case anyone was wondering. So here's what I wanted to talk about, to sort of kind of give a brief roadmap. First, I'm going to talk about the why, sort of what is integrated care, how is it different than care as usual, and the necessity that at least I see for it. I want to talk about the what, which is different models of integrated care, the continuum of integrated care and what that looks like, and how we work more from a population health perspective than an individual health perspective. I'll give a couple examples with two of the main integrated models, which are primary care behavioral health and the collaborative care models, and how they function in primary care, and then kind of wrap up with some basic talking points and things to walk away with to at least kind of keep your thinking going. So going back, the first is the why, right? Why is integrated care? Why was it developed? Why is the federal and the state, Medicare and Medicaid systems pushing for them? There's a lot of pressure from the payers and United Healthcare, HMSA, to set up integrated practices. And so where's that coming from? For us here in Maui, this was pre-pandemic, but Kaiser did a big community needs survey that covered a whole range of services from education to transportation to health. And that included mental health, substance use, youth healthcare. And some of the things that came out of that were really about mental health. And in fact, some of the main things that they brought up were very much mental health related. The barriers to this, the reason sort of this was such a concern was kind of multifaceted, as you can imagine. It depended on the number of behavioral health providers, depended what the referral process was. There was a lot of stigma and cultural beliefs about what it means to have a mental illness or have even just mental health, the concept of having mental health. And the awareness of services and availability really kind of factored into a lot of people's ability to access the system or even know that there was a system to access. If we zoom out a little bit and we look at mental health nationally, we can see this is a larger concern. This is not something that's unique to Maui or Hawaii. The most recent statistics, I think this is from National Institute for Mental Health, or Mental Illness rather, showed that of people who have diagnosable mental illness, only 46% received treatment in the year that they surveyed. I think this was from 2020. That in 2021, kind of also part of the pandemic, there was a 50% increase in referrals to psychologists So we're seeing sort of there's existing barriers to care. COVID hit, which caused an increase in referrals and an increase in people trying to get care. And then to bring in sort of the primary care part of it, people who have a mental illness also have higher rates of physical illnesses like heart disease, diabetes, different kind of chronic health conditions. So we're looking not only at the mental health aspect of things, but we're also, from a primary care perspective, we're having to look at the physical health perspective. And if people who have some sort of, mental health need are more likely to have medical needs, guess what? They're showing up in primary care. So this is also a really good way that we can help people access that care and access the mental health system, because they're showing up to primary care for what might feel like an unrelated need, but that gives us the opportunity to be able to kind of talk to them, educate, and get them hooked up with whatever services they may need. In Hawaii specifically, we have some unique aspects to our community. Similarly to the national statistics, about 50% of people who had a major depressive episode in, I think this was 2019, only about 50% of those people received any kind of treatment. So that means 50% of people who had a major depressive episode did not receive any treatment at all. The suicide rate for the Native Hawaiian and Pacific Islander community is about 43 and a half people per 100,000. To give you a comparison, the state average is 13.9. So we're seeing, this one community with a suicide rate that's 4 times higher than the state average and 4 times higher than about the national average as well. And so from a mental health perspective, are we treating these communities? Are those communities able to access the care that we give? Like, what's going on that there is such a struggle in this community that's resulting in such death? And then just kind of this idea of and the normalization of everyday life. A little over 10% of people said that their mental health was not good. That was defined as having more days than not of kind of feeling stressed or depressed or anxious in a way that it was kind of interfering with day-to-day life. So, you're still talking about 10% of the population who's experiencing, even if it's day-to-day mental, stress or anxiety, things that are getting in the way of their day-to-day. So, there's certainly a need here in Hawaii for mental health services and probably an increase in people's access to mental health and behavioral health services. The problem is only about 14% of our mental health, the need for mental health providers is actually getting met. So we are very understaffed as a state with mental health providers. This isn't super uncommon in rural areas, and Hawaii is obviously the most isolated inhabited place in the world, so I think we qualify as rural. But we're also, again, seeing there is a great need for some of these services, and there is a paucity of people who are able to actually provide those services. So from an integrated care perspective, that says, okay, then how do we increase access? How do we get people the care that they need given the workforce that we have? The other part of integrated care is also helping the medical side of things incorporate behavioral health perspectives into the care that they're giving. So the example I always kind of like to use is ADHD. We've had a lot of people since the pandemic come in and say, I think I have ADHD, I can't concentrate, I'm just having trouble getting work done, I feel very restless, very fidgety. And from a basic behavioral health or mental health standpoint, we can see, as probably most of us are mental health providers, there is a huge overlap between ADHD and trauma symptoms, right? And there's also a lot of things that are very unique to them. And so to be able to do that differential diagnosis is something that becomes important, because that's going to really determine what treatment the person gets. And those treatments are really, really different. If someone is having some sort of trauma reaction, we don't want to be giving them a stimulant to treat ADHD. It's going to shoot their anxiety symptoms through the roof. The difficulty with the medical system, though, is that most medical providers have no training in behavioral health. It's not a required rotation for most internists. It's not even, for a lot of physicians anyway, the most psychiatry or mental health training they got was maybe a 2-week clerkship in medical school. And most of that's inpatient. So, you're seeing an inpatient, very acute population, and that's your only experience with mental health provision. And then all of a sudden now you're in a primary care setting with a totally different population, trying to figure out, okay, how do I make this determination, right? But not only that, if we're looking at environmental versus neurological symptoms, right? How do we differentiate? How do we expect the medical system to differentiate what was caused by something that happened to a person, right? Versus what would be like an underlying medical condition, right? ADHD as a kind of a neurological disorder. So we're really asking them in a lot of ways to step outside of their training and look at these things and the overlap of these things and figure out treatment if we were asking them to do it on their own without a lot of tools or training to actually be able to do that. Never mind if we start looking at these things, we could also say, could this overlap of symptoms right in the middle? Could it be a substance use disorder? What if the sleeplessness and what if the sleep problems, what if they're not the symptom? What if they're the cause, right, of the difficulty with thinking and remembering and organizing things? Could it be an underlying metabolic issue, right? Is this a thyroid problem? Is this poorly controlled diabetes? Is there something going on systemically that's kind of interfering with brain function? Maybe there's an underlying learning disability that the person was never assessed for. Could this be situational, right? Maybe they, I don't know, just moved to Hawaii and their whole life is upside down and they're noticing that they're just having a hard time sleeping and concentrating and figuring things out. Or what if it's pandemic stress? We are kind of maybe at the end of this pandemic, but for 2 years we were in the middle of a global pandemic. How would we think that that wouldn't affect people? But how do we pull all of these things apart, right? If I'm a primary care provider trying to figure out what kind of care I need to be giving or want to be giving, and I have no more than maybe a very, very basic understanding of mental health diagnoses and causes and theories and all of that, the medical system is asking a lot of primary care providers to be able to do this with essentially zero training. And so what happens a lot is the primary care providers go, I don't know, go see someone else, right? Except for there isn't anyone else because we have a mental health work shortage. So this is where we start to get into ways of saying, how do we increase access to mental health and behavioral health services, given that we have kind of two different systems. We have the medical system, traditionally the medical system and behavioral health system. They don't interact very much. Patients might be going to the medical system to get their mental health care. Patients might not realize they need mental health care, never mind what their providers are able to figure out, what care they're able to provide. Do they know what to do? Do they know what resources are in the community? So this is a way that we can figure out, how we can increase access for patients by sort of integrating behavioral health into this kind of existing medical system that patients are already using.
We have a comment or question in the chat. If you could speak to insurance companies and their coverage on patient provider findings and treatment plans. Like if we do all of this together, are they not often covering these provider patient findings and plans that they come up with?
You mean like treatment plans for like behavioral health?
I'm thinking, Renata, if you want to clarify if they integrate the together and come up with a patient provider finding and plan, will the insurance company honor the service and cover the service?
Oh, yes. In Hawaii, and sometimes that's a great question because different states operate a little bit differently. In Hawaii, you can bill a medical visit and a behavioral health visit on the same day. So we do that all the time. If we do like a co-visit where like the medical provider sees the patient and then I might see the patient right after, as long as we get to that 16-minute mark, it's a billable service. So, and I'll talk a little bit more about that as we go. But yeah, these are all billable services under Quest. and the commercial plans here in Hawaii.
Okay, thank you. I think you,
Okay.
yeah.
Please keep asking questions. I'm really good at rambling.
I know Dr. Cohn has another comment that the insurance
Yeah, please.
companies don't pay for the time it takes for a primary care provider to provide mental health services.
Ah, that can get a little bit tricky with the billing. As an FQHC, we can bill for that. Medical providers are technically able to treat mental health diagnoses, so they can bill under those codes. It's a regular what they call an E&M visit, or an evaluation and management visit. It's then also coded within that of the degree of complexity. So if a patient's coming in, for instance, and kind of reporting some mood things, and they want to maybe start them on an SSRI, or kind of help get their sleep pre-regulated, that would be considered a billable service for the medical provider.
Okay, thank you.
All right, so going back to this idea of increasing access, right? How do we help patients access mental health service or access mental health care in ways that is beneficial to them, in ways that is culturally appropriate to them, and ultimately in ways that are effective for them. One of those ways is shifting to what we call a population, or what's called a population health approach. So primary care really was designed around this idea of population health. And the fundamental part of that is that you're treating sort of the largest number of people for the least acuity of problem, or the least acuity of presentation. So we can also think of population health as like public health programs, the public health announcements about wearing your seatbelt or quitting smoking. Kind of all of these things exist under that public health umbrella. Traditionally, mental health services were sort of done down here in this individual care management, right? We see one patient at a time. Our focus is on that one patient. And we traditionally, that's how I was trained. That was sort of traditional one-on-one talk therapy, right? The patient comes, you see that patient. And we're not really trained, and there wasn't really the structure or the ability for us to kind of think larger on a mental health scale. And so primary care medical care is sort of trying to do both, right? It's trying to think on a population health level, right? Which is why they're always doing a lot of, checking your blood pressure, checking your blood sugar, checking your weight, screening for different types of cancer. All of that, right, is that preventative population health. Let's catch something early and prevent it from getting worse, as well as in primary care, again, also treating some of those individual things, chronic care, acute illnesses. So they're sort of doing both because they need to, right? That's part of what healthcare provision is. What integrated health starts to do is it starts to do the same. So we go from providing individual care, and we also sort of start expanding to say, okay, how can we also provide this kind of integrated care, right? Where we're offering care services at a population health level, right? Or we're also providing this kind of care services at the individual level, and then also looking at health improvement or prevention at an individual level. And by expanding into these kind of other different parts of this quadrant, we start to have different opportunities of being able to provide care. Some of this is also going to be necessary because of the mismatch need of number of patients versus number of providers, right? We have a very small number, not a very small number, but we have a number of behavioral health providers in the state of Hawaii that does not meet the need of the populations around them, right? So for us to be able to move into some of these either preventative and population health mindsets of ways we can provide care in these two ways, we're able to actually make contact with and touch and sort of treat on various levels a much larger population than the caseload of one-on-one patients that we usually have. The best example I can give of this um, is thinking about the idea of having strep throat, right? If we used the medical system the way we've traditionally used the behavioral health system, anyone who had strep throat would have to go see an infectious disease physician, right? We always start behavioral health, mental health as individual licensed providers. We always start at this, patients always enter kind of at the level of specialty care, right? There never was a primary care behavioral health like concept, right? If you had a mental health need, you went and saw a specialist. If we sent everyone who had strep throat to see infectious disease, it would take months for anyone to get in to see infectious disease, right? That system would get overwhelmed. In the same way, the mental health system is overwhelmed, right? Because we're constantly trying to treat a population at a one-on-one level. There's traditionally never been this population health approach or preventative approach with mental health. And so kind of given that this has been the pattern, and given this has been the pattern of too few providers and too much need, the idea of integrating behavioral health into primary care is saying like, hey, we already have this medical model that works, right? Where the lowest part of the triangle is primary care. Why don't we have that? And so these integrated models are ways of sort of building into that and building into these concepts and saying, yeah, we shouldn't have everyone start at the specialist level. We need a primary care level of behavioral health where we can treat a much larger piece of the population for people that might have lower acute or kind of lower levels of need of mental health services and support, and or where we can prevent things from getting worse so they don't need to go to specialty care in the first place, which also improves quality of life, less suffering. So it's also just good practice. This idea of integrated behavioral health is actually rooted in the biopsychosocial model, which was developed in the late 70s. I think probably a lot of us use a biopsychosocial approach to our intake assessments and sort of conceptualizing patients, which is looking at the body and the psyche and the environment in which they live. This model was developed back in the 1960s with the social justice movement, when they started looking at integrating schools, integrating hospitals, and figuring out, not only were we looking at genetics and physical health, but also looking at mental health, how people responded to things, and how that environment affected the other two things, right? Why did some neighborhoods do much better in kind of their health metrics than the neighborhood right next to them? And we started to piece together the things like poverty, access to education, access to fresh food, all of these things, the environment people lived in had this huge impact on their health. And so that's where this integrated model kind of has come from very slowly, is the idea of course, our body and our mind and the environment that we live in all interact with each other, right? And if the medical system's only going to treat the biology, they're not going to get very far. And we see that, right? The United States spends more money per patient than anywhere else in the world, and we have some of the worst outcomes for that money spent. This idea of just treating the physical doesn't work. And so we need to start finding other ways as a healthcare system to figure out what's going on with patients and give them the support and the care that they need. The other reason that we have been, kind of the healthcare system has been looking at using more of these integrated models is the primary care system is already the de facto mental health system. Most people who are on a psychotropic medication like an SSRI, like Prozac, Zoloft, anything like that, 50% of those people are getting that medication from their primary care provider. They're not seeing psychiatry. So a lot of those primary care providers are already treating these things in their office. So if they're already there, why would we not go and treat the patient who's already showing up asking for help and helping those medical providers treat them in a way that's more effective? We also know that most PCP visits for a behavioral health need don't result in a referral. Some of that is PCPs don't know where to send people. They don't know what the resources are in the community. A lot of that also comes down to stigma. Patients don't want to go see the mental health person because it means they're crazy. And so there's a lot of that sort of internalized cultural or learned ideas of what it means to need mental health support that might prevent them from accessing that care. And then we have patient preference, right? Patients come to their primary care provider because they know their primary care provider. They have a relationship with them. The primary care provider knows all their other health stuff. So of course, that's the person they're going to go and say, hey, I'm having, I've just been feeling really strung up and anxious lately. What do I do? You're my doctor. What do I do? And so when providers don't know what to tell them, that's really hard on the patient, who's then like, okay, well, how do I get better? And the provider who's like, I don't know how to help this person, and that doesn't feel good, right? So if medical providers are already treating these things as mental health professionals, how can we step in and help them treat the things that are kind of already in their office anyway? Going back to kind of like I said before, we know there's a high prevalence between medical and psychiatric illnesses. So a lot of people with some sort of mental health need, which may be getting met in the community or may not, are going to be showing up in primary care to get their physical health needs met. So is this an opportunity that we have to screen to catch people who may benefit from some sort of mental health service, or to make sure people who have mental health needs are still connected to their mental health provider in the community? Again, we have this opportunity in primary care to be able to kind of do this work to keep people either connected to the services they already have or get them connected to the services that they need. And then having mental health or having a mental health provider in primary care also has a lot of implications for that differential diagnosis. Are what we're seeing and what the provider is seeing in the room actually what the provider is seeing in the room, or is it something else that looks like that thing, right? We're able to provide some of that kind of further assessment, or we know which questions to ask, or we might see that clinical picture very differently due to our background and our training than what the medical provider sees. And then we're able to join those two things together to get a more complete picture of the patient and figure out, all right, what's our next step to figure out what's going to be good for this patient. As people who study behavior and behavior change, we can also help out on that medical side, right? Is the patient taking the medication that's prescribed to them? If not, what's going on? How do we help that to happen? Or how do we help have a conversation with the PCP about why the patient doesn't want to take medication? Is the patient supposed to be, are they trying to lose weight? Are they trying to eat better? Are they trying to quit smoking? All of these things are behaviorally based. And so as behaviorists, as people who study, human thinking and behavior, at least as a psychologist, right? That's psychology, the study of human thinking and behavior. We can bring that skill set in and help, again, the things that are already coming into primary care for patients to get better faster. It's estimated usually about 70 to 80% of patients who present to primary care have some behavioral component to what they're coming in for. So again, that's, health behavior changes, it's medication, it's treatment compliance. It's all of these things that patients may be trying to do and don't know how to do or don't know how to maintain, that we can help, make a difference on those fronts too, because we understand how people work in a different way than how physicians know that people work. And so we can bring in a whole different set of skills to help patients achieve their health goals. And then we also look, again, just at that kind of population view. How are people using the healthcare system, right? How are they using the emergency department? How are they using their PCP? Can we find ways to help that patient manage, their health better so they're not needing emergency services? Going back to that prevention part, right? We want to be able to help patients partially not need the medical system or the health system as much. But we also want to, as people who work in that system, as stewards of public money, we want to make sure that people are also kind of using that system as most effectively they can to keep the system going, but also for the patient's quality of life and health, and for them to have a positive future. So I've said integrated care about 47 times. what is it exactly that I'm talking about when I say that? What does that mean? How is that different than kind of the care that we typically provide? This is kind of that a quadrant that we use in looking at different types of services uh, when we talk about mental health and behavioral health. Uh, when we're talking about integrated primary care, we're down here kind of in quadrant one, where we're talking about people who have low behavioral health needs and low physical health needs, right? The idea here is just like with physical health, most people don't need specialty care, right? Most people don't need to see a therapist for their mental health to get better. Um, because most people don't necessarily have an acuity that requires specialty care. We might not know that because we're not asking those questions, but people who are feeling, stressed, people who might just have some low-level mood or low-level sleep issues going on, those might be something kind of like strep throat that can very easily be treated in primary care that don't need to be immediately escalated to specialty care. We also know that we're missing a lot of things if we're not here asking those questions in primary care. A lot of times we're missing the stuff that is already here, and then those things remain untreated. So we want to make sure that we're getting the people who would benefit from specialty care to specialty care, so that they can get the level of care that they need, that they're going to benefit from. It also goes back to that idea of prevention, right? By being in primary care, we can provide a lot of preventative screenings and services to prevent people needing a higher level of behavioral health or medical care. So this is sort of the area that we work in when we're talking about primary care, integrated primary care. And that's why it kind of feeds into that population health model, right? Because most people, if we look at the community, have low behavioral health and low physical health needs. And so we want to be able to treat that population who, from a mental health perspective, has traditionally not really gotten any sort of service or any sort of care at that level. Integrated health or integrated behavioral health, sort of formal definition, this idea of working together with patients and families, right, the rest of the healthcare team, providing this sort of patient-centered care for this specific population, this kind of primary care population. And then being able to address things that maybe a traditional mental health provider wouldn't address or wouldn't necessarily be able to address outside of a medical setting. So not just mental health and substance use things, but also looking at health behaviors. I'm a health psychologist by training, so a lot of I used to do transplant evaluations, amputee clinic, teach people how to inject insulin because people get kind of anxious about jamming a needle into their leg. And so there are kind of things that are specific to the healthcare system that we're able to provide some of those services when we're actually in that setting. We can address just the life stressors and sort of mini crises that come up, on people's day-to-day who might be in primary care. That they might just need 20 minutes to sit down and talk through something, and get some concrete next steps, and they're good to go. So we're able to provide that. We're able to look at kind of the physical symptoms that patients might not necessarily talk with their mental health provider about because they may not see them as being, stress related or connected to their mental health. The same way that they might come in and talk to their PCP about the physical symptoms, not realizing that it's connected to their mental health. So again, we get to work with the medical providers to get that kind of larger picture. And then again, going back to kind of more effective patterns of healthcare use. So the same way that we give people, inhalers for asthma and tell them here are the things that we would recommend that you do or don't do to prevent an asthma attack, we can kind of do some of those same things with mental health. How do we use the services that exist, the crisis line, a mental health provider, primary care, to prevent kind of just the default of going to the emergency department?
We have a question in the chat if in this model you work with medical providers who have a challenge with particular areas of delivering care.
I think to talk really briefly, I think some of it is. I think if we talk about something like diabetes, Insulin, metformin, sort of the medications that get prescribed are kind of one part of that care, but the vast majority of that care is, physical activity, diet, what people are eating, how much they're eating, kind of doing the reading the food labels. How do you navigate like family gatherings where everyone's trying, their auntie's giving you, plate after plate of food. The holidays, right, when there's a lot more kind of cookies and celebrations and things. All of that part of like diabetes care, for instance, is behavior. And so kind of going back to, if a medical provider knows how to prescribe insulin and metformin and kind of do the lab work, but 90% of the treatment for that condition is behaviorally based, yeah, they're at a real deficit of how to, help people make those changes. And so that's where we, again, I kind of as behavioral health professionals can come in and help do that part of care in conjunction with the medical part. For me, the medical provider, and the patient to say, what's the goal here and how do we get there? Because now you've got kind of two professional skill sets that we can throw at this to come up with a treatment plan that works. Also, again, some of the traditional just mental health things, either patients that maybe transfer in with existing mental health conditions, or people that come in with just, I feel really down, or I just feel really stressed out, or I'm not sleeping. Again, a lot of primary care providers don't have a lot of training, if any, in how to assess those and treat those. So, we're able to sort of provide some of that coaching to the provider, or do that assessment ourselves and then come back and say, hey, here's what I found out, here's what's going on, here's what I would recommend. So yeah, that's absolutely a role of what we do in primary care, is kind of consulting with the medical providers on any of those things.
And there's another question that came in through the messages. Aren't PCPs already overloaded, just like how mental health providers are? But I'm thinking that that's the idea, is to alleviate some of the workload on each side. But maybe you could speak to that a little.
Sure. Yeah, absolutely. I think any of us that have tried to get a last minute appointment with our primary care provider know that their schedules are booked. And certainly, we are here. And so kind of like what Summer said, that's exactly also sometimes the role that we play. Sometimes if the patient's coming in, for feeling depressed, I'll see the patient, and the PCP won't. Because if I go in and see the patient and we talk through and we come up with a good plan, patient got what they needed. We've got a plan of what to do next. Primary care provider didn't need to them. Cross them off their schedule, right? That opened up, that slot and kind of made their schedule a little bit easier, gave them more time with other patients. In the primary care behavioral health model, which is a lot of what I work in, really my role is as a consultant to the primary care provider. I'm sitting over in primary care doing exactly that. Or let's say the patient, we're trying to make some changes and get their diabetes under control. The medical provider might go in and do kind of their thing, do need to make any med adjustments, kind of go over lab results, what's going on, and then come out and talk to me and say, okay, here's what's happening, we've tried this. It sounds like a lot of this is about food access and food choices. Can you go in and talk with them about that? And I'll go, sure. And so I'll go in and say, let's talk about, what kind of dietary changes have you tried to make? What was hard? What was easier? Are there barriers to accessing food or getting to the grocery store? What are the cultural factors that are going to factor into food choices? And I can kind of do that assessment and say, okay, here's what I think you can do to help sort of get closer to that goal. And then I'll go back to the PCP and say, hey, okay, here's what we talked about. Here's what we want to do on the behavioral side. How does that sound? And they'll go, if they're like, yeah, we can do that, I'll go, great. And then the PCP might have the patient come back in a month, and we can see kind of how things went from that. So the PCP might only have to be in that visit for 15 minutes, and then I can go in and talk to the patient for 30 minutes because I can do that. And the medical provider could do that too, but probably not as well as I could. They don't have that training. And also, I want the medical provider to go see the next patient who had a hospital follow-up for a heart attack, right? I can't do that. So some of this is also saying, like, let's let medicine practice medicine and let the behavioral health people practice behavioral health, and not try to make the medical providers be a behavioral health provider because that's not really working. So yeah, you can shift that workload around to say what kind of percentage of the patient visit requires a medical provider and what percentage of that visit would benefit from the behavioral health provider. And so you can really shorten down sometimes the amount of time the medical provider has to be in the room by having the behavioral health provider and go in and kind of take over that visit if needed. And again, in primary care, we can actually do that really pretty frequently because of how much things that come in that have some significant behavioral component to it.
Great. Thanks, Dr. Nead.
For sure. So talking about integrated care, we kind of talk about it on this continuum, right? Traditionally, mental health has been sort of down on the left end with coordinated care, right? We're kind of medical and mental health were sort of two siloed, different systems, different treatment plans, different providers, not really talking to each other very much. Really kind of doing two separate things in isolation from each other. Maybe there was some communication back and forth, but not too much, right? This is also, again, traditionally how specialty care has worked for medicine, right? The patient goes and sees a specialist, they do their thing, they send the notes back to the primary care provider. Maybe there's a phone call, probably not, but it's really sort of two people doing kind of two different things with treating two different diagnoses, two different treatment plans. As we get more towards the middle of this continuum, we start to see sort of more what we call co-located care. And co-located care might still be sort of these two different services doing two different things with two different treatment plans, but they might be in the same clinic or in the same building, right? It really facilitates the patient being able to access both and sort of increases some of that awareness and communication between the medical side and the behavioral health side. Even if they're not sharing patient information or sharing like patient files, they have a better understanding of who each other is. There's having kind of an easier way to get the patient back and forth between those two services because they're in the same place. And so it really just facilitates that connection. You may also have kind of a co-located, what they call here, close collaboration on site. So for instance, we have some providers here who kind of would fit more of this definition. They're providing traditional mental health care. They're doing kind of the long-term psychotherapy, but they're charting in the same medical record as the rest of us. They're using the same notes. They're using the same problem list. What they're doing kind of integrates into the system, and we have access to that in the same way, so that even though we're doing two different things, we can look over and see how things are doing on each side. And then as we get over more to the integrated side of things, we start to look at sort of that closer collaboration, where we're really looking at how are we part of the primary care team. That might be short-term therapy or short-term interventions. That might be the sort of the on-the-spot consults. That might be co-leading medical appointments. And at that point, you're really using the same EMR, same treatment plan, same patient panel. I've seen places where the behavioral health provider charts in the same note as the primary care provider. So that primary care visit just has one note, and the behavioral health provider and the medical provider have put their stuff all in that one note. So again, it really runs kind of on a continuum between kind of two really separate, really different types of services to kind of behavioral health being just as much a part of the primary care team as the medical provider is, and then everything in between. That can seem really daunting sometimes and kind of weird, except if we look at this, there's actually a lot of overlap between what behavioral health or what mental health does and what primary care and what medicine does, right? Being able to screen people for different disorders or different needs, address different diagnoses, talk about medications, have that collaboration, change the treatment plan when it's not working. We can do all of these things together, and also we have these other two kind of sets of skills that the other doesn't, right? So by integrating together, we not only have these things in common we can sort of understand and do together, we also have these unique skills that we can bring in to help the patient as well, because we have these things that the other part of the team doesn't. So in the interest of time, I want to talk over quickly two of the main integrated care models that are kind of most commonly used when we talk about integrated care. One of these is the primary care behavioral health model, in which the primary care provider is embedded in the primary care clinic as part of the primary care team. Really, it's this idea of whatever the medical provider is treating is what the behavioral health provider is treating. So, you're talking about working kind of side by side, shoulder to shoulder, being immediately available for a consult for that patient that's in the office. Typically, like when I'm doing that, I might meet the patient 15, 30 minutes for different reasons, depending on what the primary care provider needs. That could be clarifying a diagnosis. It could be doing some sort of brief intervention, like talking about sleep hygiene or talking about stress management or time management. Or it could be follow-up, right? Just like we have medical follow-ups, we might have that same follow-up. Okay, last time you were here, we talked about X, Y, and Z, and doc did this with your meds. Looks like your labs are better. What worked? Like what happened? Because this looks like you're moving in the right direction. How do we keep that going? We also sometimes connect to community services. So that might be sort of doing that assessment and saying this patient needs kind of a level of behavioral health care that's more than what primary care is, and how do we get them connected to that service? It might also sometimes be connecting them to food banks or transportation or group therapies, AA, things like that. Again, kind of as the specialist, we just have an awareness a lot of times of those community resources that medical providers don't. I report back then to the PCP, kind of a verbal report, the same way that the PCP reported to me of kind of what happened in their session and what they're looking for from me. I go back and say, okay, here's what we did, here's what we talked about, here's what I found out. And we kind of incorporate that into whatever the follow-up plan is going to be. That all gets charted in the same EMR as the medical provider. Maybe I might see patients, separately, individually, if we determine that this is primarily a behavioral health thing and not a medical thing. So sleep is a big one, right? It's about sleep behaviors. It doesn't really require medication. It requires some just consistent behavior changes. And then again, referring out to the community if needed for care that kind of is just beyond what primary care is. So we address just a lot of these things that are very common to primary care. We do the thing, the traditional kind of mood and affective needs that people come in with. We address the behavioral aspects of physical illnesses or coping with physical illnesses. We talk about health behavior change. We talk about social challenges, right? What are those barriers to care? Or those social determinants of health that we may be able to help kind of alleviate or reduce the impact that it's having on that patient's care. This sort of is a quick and dirty chart that sort of shows some of the differences between what a traditional mental health provider does and what the behavioral health consultant does in those visits. So some of the things are kind of similar, and some of the things are pretty different, right? So these are the things that are kind of the things that are very different from a traditional mental health provider. It just sort of shows a lot of times this mirrors a little bit more of what the primary care provider is doing than what kind of a mental health provider would be doing. And that doesn't make anything right or wrong, but it kind of gives it more of that primary care feel and allows for a different type of access for patients when it's in the room, sort of there happening, and we're able to do it on the spot for whatever need they're having at the visit they're already there for. The other main model that we use, and it's kind of used more, is what we call the collaborative care model. This is a way to provide kind of an increased amount of psychiatric care and med management into the primary care setting. This is done primarily by using a behavioral health case manager, which could be a licensed provider, or maybe like a nurse or like an LSW. Or this pediatrician, I was using this slide for another presentation earlier this year. But the primary care provider who's going to do the medication prescribing and sort of monitoring overall medical care. And then you have a consulting psychiatrist who's sort of monitoring the registry that's tracking the patients in the program and working with the behavioral case manager and the PCP for any med changes that may need to be made or that the primary care provider isn't sure of how to make. The idea here is that predominantly what's happening is the behavioral health case manager and the patient are working together, and then the primary care provider is sort of looking at the overall health of the patient, making any med changes that might be needed. The psychiatrist is really only there in a consulting role to the primary care provider. They're keeping an eye on the registry that the behavioral health case care manager is using to see, are patients getting better? If not, are there any med recommendations they would change? Do we need to clarify a diagnosis? They can kind of step in and help figure out that side of things. The reason this has become more and more used is, as a consulting psychiatrist, we have a psychiatrist we work with. In about 2 hours of patient chartings, she can go over like 20 to 25 patients and make med recommendations in a 2-hour period, right? As opposed to if she saw all of them one-on-one, the amount of time that would take would be far greater. So getting back to this idea of being able to increase access by using the mental health system in a little bit of a different way than we traditionally do, the idea of having the consultant as the psychiatrist as the consultant instead of the direct care provider, and using the system, the primary care system that's already there and already running, allows the other parts of the system to do a lot of the work, and the psychiatrist is just there when needed to help make whatever changes or tweaks on the medication side that may need to be made. Therefore, allowing a lot more people to be treated per psychiatrist, and we all know psychiatry is really hard to get to. So again, this is just another way of being able to provide care in a bit of a different way, using kind of the pieces of the mental health system that are already there. So I know we have like 3 minutes. I skipped over some slides, but where I think Summer has the slides and the printout. So we'll make sure that anyone that wants it gets them. You can also please feel free to contact me directly. I'm happy to send those out, or any other questions. Like I said, I talk a lot, so I ran out of time, but I wanted to leave at least a few minutes in case people had any other questions or clarifications.
Thanks, Dr. Nead. We had a question back about the insurance coverage. If counseling services are covered, if they're provided by the primary care physician.
Technically, yes. Technically, medical providers can provide counseling services. Again, they can bill under the E&M codes, kind of the regular office visits codes that they use, but there's a diagnosis code, what's called a Z code. It's something like counseling for mood concern, or it's phrased a little bit differently, but it's one of the ICD-10 codes that, at least for us in an FQHC, is a billable service. The question a lot of times there becomes, ethically, what are providers comfortable doing, and sort of what's within their scope of training and their scope of experience. I think technically they can even bill the CPT codes that we tend to use for therapy, but most providers wouldn't, because they would consider it kind of outside of their scope, and it wouldn't be ethical for them to provide kind of counseling.
Thank you. And then we have Dr. Marita says that she agrees that integrative medicine is definitely the way to go, and she appreciates the interdisciplinary team approach to patient care. In all settings of healthcare delivery, addressing behavioral health is essential, and having behavioral health access for recommendations to the providers is ideal. And not to make excuses for them, but work for PCPs are brutal in meeting a multitude of government agency determined care goal measures. And Renata seconds that. Just wanted to.
Sure. We have, in the healthcare system, we have UDS measures that we have to report to the federal government. We have HEDIS measures we have to report. For us, we have PCMH, which is a primary care medical home requirements that we have to meet to maintain our certification. Some of the insurers are getting into things like value-based care, where they're paying less for the per visit, but they will reward you for increased patient health, right? So if your average A1C, which is another measure of diabetes, is at a certain number, you would get sort of almost like a higher per visit pay, because they're encouraging you not to just see patients more often. They're encouraging they want the patients to actually get better, right? Kind of move away from just fee for service and get into actually like fee for health. A lot of teams are using behavioral health providers on that because so much of people's health in primary care is based on behavior. So again, I see people who have diabetes and their numbers just aren't coming down for one reason or another. Same thing with things like hypertension, high blood pressure. Is it a compliance thing? Is it a diet and exercise thing? Is it a stress thing? So I think there are a lot of opportunities for behavioral health to be involved because of some of these changes, not only in how the medical system is sort of, and medical providers are getting paid, but also because of some of those measures that people are starting to get looked at. And I agree. I'm married to a physician who's a primary care, a PCP. We are asking way too much of our primary care providers. Like it's an impossible task. And so I also think some of this integrated models and integrated care is necessary just to keep the primary care system running in the long term, because we are burning out primary care providers at a dangerous rate. A lot of medical students aren't going into primary care because it's one of the lowest paid areas of medicine. So it really is an opportunity for us to be able to step up and find new ways to step up and contribute on this primary care level that just wasn't open to us before. And I think that we just, as mental health providers who were trained in a very different way, we didn't even know there was a need there, right? And we certainly weren't trained to meet that need. So it's kind of a really exciting time to see kind of how the medical system is going to change, and it is, and the role that kind of we can have in that change.
Karen sends a question in the chat. Are health educators part of primary care anymore? Oh, and Dr. Marita says health educators are part of the interdisciplinary team in some settings such as Kaiser.
Yeah. Health educators, like we have CHWs who do some like health education classes. That's a non-billable service though. They're not licensed. That's not education, unfortunately, isn't something that's billable. We're seeing some movement on that because the idea of preventative care in that way is really catching on. Physicians can bill for like your annual wellness check is a billable visit they can do. That is just education and sort of keeping you healthy, not making you healthy. We don't have a behavioral health version of that, right? Everything has to be diagnosed, like it has a diagnosis attached to it. And we find some ways to bill that are not kind of over pathologizing normal life. And the system is starting to catch up. There was some new codes, diagnostic codes released in October. What is it, F32.A, which is just depression, not depression disorder, not major depression disorder, just depression as a symptom. And that's the first time we as behavioral health providers have been able to bill for a symptom and not a full-blown disorder. So I think the system is changing. I'm hoping those education parts, that preventative stuff on our side will become a billable service because it's vitally important. It's just really slow for the systems and the payers to figure that out and then change it, especially when you're talking about Medicare and Medicaid and federal dollars and state regulations and all of that.
Okay, thank you. And we are past one. Thanks for everyone who stayed on. Any other last questions for Dr. Nead? We want to respect his time as well. A lot of thank yous coming through the chat. Definitely super important.
I can stay on if that's an option. Otherwise,
yeah.
This is my email. Please feel free to reach out with any questions. I've got a lot of materials. And again, I did skip a lot of slides in the essence of time. But if you want a copy of that or somewhere, I don't know if you're going to send it out.
Yep,
there will be kind of, okay, there'll be there's more information on especially those two models. So read over that. Also, none of this is proprietary information. You can Google everything I talked about and find lots of CEUs, webinars, textbooks, Um, so if you're interested, like please do explore. Again, I'm happy to point you in the right direction. Just shoot me an email. But yeah, if you find this at all interesting, do a Google search. You can find all kinds of ways to expand the skill set that you have.
Yeah, thanks so much. So, Dr. Need's slide deck and all of this information is on our Echo resource page. I did put the link in the chat.